today we will discuss and start with the drugs that mainly affects the coagulation and bleeding. So basically we will discuss about the coagulant drug, anticoagulant drug today, and in the next class we will discuss about the rest part of the anticoagulant and other drugs that are related like antiplatelet drug, fibrinolytic, antifibrinolytic, etc. So already in the physiology you have read about the coagulation. Blood needs to kept in the blood vessels within the fluid state, okay. But when there is some problems in the endothelium, the blood have to be clotted, otherwise there will be incessant bleeding. So there are different factors that mainly interplay with one another to maintain a fine balance between a thrombus formation like total coagulation as well as the fluid state of the blood. So when there is problems, there will be either there will be more bleeding or there will be more thrombus formation or blockade of the artery as well as the veins. When the blockade occurs within the artery, that is known as the arterial thrombus, and when the blockade occurs within the veins, it is known as the venous thrombus. So arterial thrombus, most common example is when some coronary artery there is arterial thrombus and myocardial infarction or heart attack can happen. Venous thrombus example is when there is stasis of the blood, there may be some venous thrombus or venous thromboembolism, and there may be some leg pains in the leg vessels, there may be some venous thrombosis, deep vein thrombosis. So in this there are, apart from on the other side, if there is problem in the coagulation, problem in the different proteins that help in the coagulation, that leads to more bleeding. For example, there are hemophilia. You have heard in the physiology, hemophilia mainly happens due to the factor 8 or factor 9 deficiency. There are von Willebrand disease, another disease that happens due to the qualitative or quantitative deficiency of the von Willebrand factor. Von Willebrand factor is another factor that is needed in the coagulation that basically functions in accordance with the factor 8. There may be some disseminated intravascular coagulation where the coagulation is more like that needs to be intended. So these are the areas where there will be more bleeding, and the previous ones are the areas there will be more coagulation. So there are some drugs that helps in the more coagulation of the blood that is mainly needed when there is more bleeding, and these are known as the coagulants. The most common coagulants is the vitamin K, okay. So you have already heard about the vitamin K, you have read about the vitamin K in the physiology. So vitamin K is a fat soluble vitamin like A, D, E, K. There are 4 fat soluble vitamins, and it has been seen, there was a scientist known as the Dam. He has seen that if there is deficiency of the vitamin K, that leads to more bleeding, and it has been seen that if there is more bleeding, mainly it is done in the chickens, that if we are providing them with some vitamin K, that leads to ultimately management of the disease. So from this, the name of the vitamin K comes. K mainly in the previously, K stands for the coagulation. KOA, previously this coagulation is spelled at KOAGULATION. From this K, it comes that the vitamin K, okay. So vitamin K is the main coagulant, and within the main anticoagulant there are different drugs. And already in the physiology you have read about the coagulation cascade. So when there is some injury to the vessels, first there will be vasoconstriction, and then the platelets are activated. So platelet phase weakens. So platelet activation happens due to the activation of the different proteins within the plasma. So platelet adhesion happens, platelet aggregation happens. So ultimately a platelet plug is formed, okay. So this platelet plug have to be anchored to the endothelium to stop the bleeding, and this anchoring is done by the coagulation factors. These coagulation factors are mainly prepared from the liver, in our liver, okay, and they are present in a zymogen form, that is inactive form, and these inactive forms coagulation factors have to be activated to action in this coagulation cascade, and this activation happens, there are some proteins that activates this, and ultimately one activated factor activates the zymogen of the next cascade of the activation factors. So there will be a cascading reaction. So ultimately, due to this cascading reaction, there will be formation of the fibrin. Fibrin plugs is formed, and this fibrin is associated with the platelet plugs, and thus the coagulum or the clot is formed. Now this clot should not be continue for an unknown time. So when the bleeding is stopped, everything is normal, this clot has to be again dissolved. So this dissolved is again done by means of another system known as the plasminogen system. So this plasminogen from this plasmin is generated and ultimately dissolves this fibrin meshwork. So this is in nutshell the common cascading reactions. Okay. So when we need anticoagulation, we have to use some drugs that ultimately limit this coagulation cascade. The most common anticoagulant drug intravenous we use is the heparin. Heparin is also present in our mast cells, and it is synthesized from the bovine or pig intestinal cells, and ultimately it can be used outside. So then heparin is basically acts indirectly to increase this coagulation cascade. Apart from heparin, there are other drugs that acts directly to increase this coagulation cascade. Okay. So ultimately there is anticoagulation. So they are basically blocking this coagulation cascade at several levels. We will discuss about this all. So let's just start. What I am talking, that hemostasis, arrest of the blood loss, already we have discussed. So that ultimately starts with two systems. This coagulation cascade mainly acts by intrinsic system and extrinsic system. Okay. So this intrinsic system mainly starts when the pathway is responsible for clotting, when blood is kept in a glass tube. That is, intrinsic system first starts usually in vitro states. For example, your plasma is taken out and it is kept in a glass tube. Here the intrinsic system starts first. But when there is any injury to our endothelium, usually the extrinsic system starts first due to the presence of the tissue factor. This tissue factor activates the factor 7, and ultimately this factor 7 activates the other factors in the intrinsic pathway as well as the common pathway. The hemostasis, first there will be vascular phase. Vascular phase is the vasoconstriction, already I have discussed when there is any injury. Then comes the platelet phase. So platelet phase, there will be platelet adhesion and platelet aggregation happens. And there are, you can see, different receptors and different agonists, different proteins are orchestrating this platelet adhesion and aggregation. For example, you can see this collagen, von Willebrand factor, ADP. So these are basically procoagulants, and they activate these different receptors like P2Y1, P2Y2 or PAR, PR4, etc. And ultimately this ULO is one platelet, this ULO is another platelet. There will be platelet adhesion, and then the fibrinogen comes and they attaches one platelet to another platelet and platelet aggregation happens. Coagulation phase is the intrinsic and extrinsic. This pathway already I have discussed. So extrinsic system, when there is tissue damage, the factor 7 is released. It is activated to factor 7A, and here in the activation factor 12, factor 11 and kallikrein also plays a role, and with the help of the tissue factor 3 and the calcium, it converts the factor 10 to factor 10A, and this factor 10A ultimately activates upstream in the intrinsic system so that there will be more amplification of its own, that is amplification of the factor 10 itself as well as the other clotting factors. That all leads to the formation of this common pathway, more conversion of the prothrombin to thrombin, and this thrombin converts the fibrinogen already present in the zymogen form to the fibrin, which is a soluble form. This fibrin, with the help of the thrombin as well as the factor 13, is converted to the insoluble fibrin, and this insoluble fibrin basically forms the meshwork that inserts within the platelets, and then they form the platelet adhesion, aggregation, and ultimately a coagulum is formed. So you can see this is the intrinsic system and this is the extrinsic system. And when a blood is kept outside in vitro, usually the intrinsic system starts earlier. There will be no relation of the extrinsic system. In the intrinsic system, you can see factor 12 is converted to factor 12A by high molecular weight kininogen or some glass particles that is present within the test tube that converts 11 to 11A. This 11A with the form of the calcium converts 9 to 9A, and this 9A with the help of the factor 8, activated form of the factor 8, converts again to 10 to 10A, and from this the common pathway begins. So from factor 10 the common pathway begins, and before the factor 10 there will be two pathways, extrinsic pathway and intrinsic pathway. So is it clear? So when there will be a cut in us, if there is some cut in my hand, there will be first activation of this extrinsic pathway. Because the tissue factor comes, the endothelium is breached, and this tissue factor with the help of the calcium, and these are kallikrein, factor 12A, 10A, etc., it converts 10 to 10A. Minute amounts of the 10A is formed, and this 10A ultimately leads to more generation of its own 10A by means of this intrinsic system. This is known as the upstream activation of the factor 10A or amplification of the factor 10A. So this is the amplification happens by means of the intrinsic pathway, and ultimately the common pathway comes where the factor 10A ultimately converts the prothrombin. Prothrombin is the factor 2, converts the prothrombin to activated factor 2A, which is known as the thrombin. This thrombin converts fibrinogen to fibrin, and then ultimately fibrin mesoswap forms. Apart from this, you have already seen this thrombin also helps in the platelet adhesion and aggregation. So this thrombin also helps in the other ways also. So by this way the intrinsic and extrinsic system and coagulation cascade usually functions. And you can see this H is the heparin. Already I have said the word heparin. So heparin is the traditional and main anticoagulant that mainly acts in these areas. So heparin you can see acts in these areas. So mainly heparin acts in these last two areas, conversion of prothrombin to thrombin and conversion of factor 10 to 10A. And in the upstream they also blocks this area. Then comes the fibrinolytic phase. Already I have told that it should not be relentless. So ultimately when a coagulum is formed, it has to be destroyed when the function is over. So if this destruction is done by means of plasmin, and this plasmin is again formed from the plasminogen. Plasminogen is again present in our body, which is again synthesized from the liver, and it is converted by means of the tissue plasminogen activator, and this ultimately destroys the fibrin mesoswap. So ultimately the clot or coagulum goes away. So now coming to the coagulants. So when there will be more bleeding, we need more coagulation, and this can be done by the coagulants. Already I have said that vitamin K is the typical coagulant. Vitamin K is available in different forms. So remember the most commonly used form is the vitamin K1 or phytonadione. Apart from this, there is vitamin K2 and vitamin K3. What happens? Vitamin K1 is available from different vegetables or different like for example alfalfa grass, cabbage, spinach. From this contains large amount of the vitamin K. Apart from this, there are animal sources also like different animal liver. So from this vitamin K is obtained, vitamin K1. Vitamin K2 is mainly synthesized by the microorganisms in our gastrointestinal system. So this is known as the vitamin K2 is known as the minadione. Okay. So vitamin K2, the total amount of the vitamin K, 50% is synthesized in our gut by means of the microorganisms, and rest 50% has to be taken from the outside. And vitamin K3 is the synthesized form of the vitamin K, which we can form in the laboratory and which is also water soluble. So when the vitamin K deficiency will happen, if there is some inadequate dietary intake, but that is rare. Next is if there is some malabsorption syndrome, again if there is some tropical sprue or celiac disease etc., there will be less absorption of the vitamin K, and there is also changes in the normal commensal gut microbacterium. So when there is change in the normal commensal gut microbacterium due to malabsorption syndrome or due to some hepatic problems, there will be less synthesis of the vitamin K2 in our gut. So again there will be some problems in the vitamin K. If there is some obstructive jaundice, if there is some liver disease, again there will be problems in the vitamin K. So these are the normal areas by which the vitamin K deficiency usually happens in the adults. But in case of the infants, usually in case of the premature infants, already the vitamin K is low. That's why in premature infants and after birth, in all case of the infants, we have to administer the vitamin K injection. So vitamin K is mainly acts as a cofactor in the synthesis of the 4 clotting factors 2, 7, 9 and 10. Okay. So prothrombin factors, prothrombin is the 2, 7, 9 and 10. So when the vitamin K is deficient, these coagulation factors will not be formed 2, 7, 9, 10. So already we have said from the 10 the common pathway begins and factor 7 is needed in the extrinsic pathway. So 2, 7, 9, 10 will be deficient when the vitamin K is deficient. Deficiency of vitamin K occurs due to liver disease, obstructive jaundice, malabsorption syndrome, long-term antimicrobial therapy, another thing. So if a patient is taking some antibiotic for a long period of time, antibiotic ultimately kills some of the commensal good bacteria in our gut also. So that also leads to vitamin K deficiency in long-term antimicrobial therapy. Remember, deficient diet is rarely responsible because it is ubiquitous in the nature. The most important manifestation is the bleeding tendency due to lowering of the levels of the prothrombin and other clotting factors in the blood. So 2, 7, 9, 10, remember these are the 4 clotting factors that are synthesized in the liver, and this synthesis needs the action of the vitamin K. So vitamin K is used in dietary deficiency, but it is rare. Prolonged antimicrobial therapy, already you have discussed. Obstructive jaundice or some malabsorption syndrome, we have to use the vitamin K. Different types of the liver disease, newborn babies, overdose of the oral anticoagulant, we will discuss this later. Because this oral anticoagulants, if there is overdose, we have to use the vitamin K to replenish it. Prolonged high dose salicylate therapy is also decreases the vitamin K level. So overdose of the oral anticoagulants may happen. This is one of the most important indication of the vitamin K. We will discuss later about the oral anticoagulants. The most common is the warfarin. So this oral anticoagulants basically acts with the help of the vitamin K. So phytonadione K1 is the preparation of choice when there is overdose, when there is bleeding, because it acts most rapidly. Dose depends on the severity of the hyperprothrombinaemia. All newborns have low levels of the prothrombin and other clotting factors because this clotting factor generation machinery is not developed in the newborns, as well as there are deficiency of the vitamin K. So the defect is exaggerated in the premature infants. So prematurity ultimately leads to hemorrhagic disease of the newborn. The newborn, there will be hemorrhage. So vitamin K 1 milligram intramuscular soon after birth has been recommended routinely. Usually both in the normal neonate as well as in the premature, immediately after delivery we have to give the vitamin K intramuscular injections. Otherwise, in some of the cases, pregnant women vitamin K injection is also given 24 to 48 hours before delivery, but the dose is higher. Menadione or its water soluble derivatives can cause hemolysis in dose dependent manner. Menadione is the synthetic form, vitamin K3. It is usually not given in case of the newborn babies because there may be problems. Patients with G6PD deficiency and neonates are easily susceptible for the problems, because in the newborn, if we are giving the synthetic form of the vitamin K, also known as the vitamin K3 or menadione, that can induce the hemolysis and increase the bilirubin load and competitively inhibits the glucuronidation of the bilirubin. So that's the problem. So usually we are using the phytonadione or vitamin K1 intramuscular or given orally. Usually that will not produce any type of adverse drug reaction. Severe anaphylactic reactions can occur with IV injections, but with intramuscular injections the adverse effects are less. So the take home point is, in case of the neonates, we have to administer the vitamin K injection immediately, usually 1 milligram intramuscular, one shot is given. This is particularly more useful in case of the premature babies. Usually the vitamin K1 or phytonadione is given but the synthetic forms of vitamin K3 usually not given because that can lead to more chances of the hemolysis, more bilirubin load, and that bilirubin can ultimately deposit within the basal ganglia that can lead to kernicterus. So that babies are more prone to this kernicterus. So usually the synthetic form is not given. Apart from this vitamin K, there are some other types of the coagulants like desmopressin. Desmopressin is a drug that ultimately releases the factor 8 and an von Willebrand factor from the vascular endothelium and checks bleeding in hemophilia and von Willebrand disease. So already we have discussed about the hemophilia. So hemophilia is factor 8 deficiency most commonly, or factor 9 deficiency. This is also known as the Christmas disease. The manifestations are more or less similar. In hemophilia, since the deficiency of the vitamin coagulation factor is there are more chances of the bleeding, easy bruisability. The most commonly there are bleeding in the joints, hemarthrosis. It is known as the hemarthrosis, and ultimately with recurrent hemarthrosis there will be ultimately disability in the joints will develop. Apart from this, there may be bleeding from the nose, bleeding from the different areas can happen. So the treatment is we have to give the factor 8 concentrate, or in case of the Christmas disease we have to give the factor 9 concentrate. And von Willebrand disease is another disease that is intricately linked with this hemophilia. Von Willebrand disease is again an autosomal dominant disease mostly, and there are three types of the von Willebrand disease. Von Willebrand disease 1, 2 or 3. Usually the 1 and 2 are the mild one. Von Willebrand disease type 3 is the very severe disease. But 70% cases of the von Willebrand disease are mild, which usually manifest that there will be delayed wound healing, there will be some bleeding from, there may be some epistaxis, there may be bleeding from other areas can happen. So there are mainly, it has been seen, there are qualitative or quantitative defects of the von Willebrand factor. This von Willebrand factor is associated, attaches with this factor 8 and ultimately they helps in the coagulation. So when there is some von Willebrand factor deficiency, the coagulation cascade also there will be problems. So in these diseases we can use the desmopressin. Rutin is a plant glycoside that claim to reduce the capillary bleeding. Ethamsilate is another drug that is also commonly used that basically reduces the capillary bleeding when the platelets are adequate. So the platelets are normal, there will be no thrombocytopenia, and probably they exert anti-hyaluronidase actions or corrects abnormalities of the platelet adhesion, but does not stabilize the fibrin. So it is not stabilizing the fibrin, they mainly acts by modulating the platelet adhesion, ethamsilate. It is basically used in the treatment and prevention of the capillary bleeding in menorrhagia, when there is increased menstrual bleeding. After abortion, so after abortion there will be more chances of the bleeding. Postpartum hemorrhage, so after delivery, if there is severe bleeding, we can use. Epistaxis, bleeding from the nose. Melena, that is blood in the stool. Hematuria, blood in the urine. And after tooth extraction. So in these cases, we can use the ethamsilate. They basically acts by decreasing the capillary bleeding by modulating the platelet adhesion when the platelet count is normal. Okay. Fibrinogen itself can be purified and can be used. Mainly it is used in case of the hemophilia. Adrenochrome mesocarbamazine, it is also less used, but it can be used in epistaxis, hematuria, etc. They mainly control the oozing from the raw surfaces, like after teeth extraction. In case of the hemophilia, there will be more bleeding. Sclerosing agents, so they are basically sclerose, contracts the blood vessels. So they are irritants, cause inflammation, coagulation and ultimately fibrosis when injected into that area. Mainly it is used in case of the hemorrhoids, that is the piles. So when there is bleeding piles, that is from the hemorrhoids blood is oozing out, we can inject the sclerosing agent so that the dilated veins can be sclerosed. Okay. Or varicose vein. Varicose vein is also varicosity is seen in case of the veins, most commonly in the leg veins. Here we can use the sclerosing agents. They are used only for local injection, that is in that area we have to inject. So this is an example of local injection where the pathology is. This is not given in the intravenous or intramuscular or subcutaneous. It is given at that area, in the varicose vein, at that veins. in the hemorrhoids, bleeding hemorrhoids, at that areas, we have to inject. Example, sodium tetradecyl sulfate polydocanol. Another is local hemostatics, or also known as the styptics. Styptics is basically mesh work, mesh. So after injury to arterioles or smaller blood vessels, control of the bleeding may be done by this, mainly effective in oozing surfaces like in the tooth socket after tooth extraction, abrasion after some operations inside. So these are usually prepared from the absorbable material like fibrin. So from the human plasma that contains fibrinogen, and from this fibrin is extracted, purified, and they are mainly formed in some mesh work like pattern. Oxidized cellulose. So they ultimately provide a coating or mesh work which activates the clotting mechanism and checks bleeding, and after approximately 2 to 4 weeks time it absorbs on its own. So basically these are the local hemostatics or styptics. This can be used after in case of the like hernia operation. After this we have to insert some mesh like this. So now coming to the anticoagulants, already we have discussed about the arterial thrombosis and venous thrombosis, and this thrombus can be dislodged and they can form as a embolus and can form the thromboembolism. They can block the blood vessels anywhere in our body. Okay. So some anticoagulants can be used both in vivo and in vitro. For example, heparin. In vitro means when we are testing our blood. So our blood is drawn and it is kept in the test tube, but it has to be in the fluid state. Otherwise, we cannot test it, if there is coagulum is formed. So in vitro, so heparin can be used both in vivo and in vitro. Apart from, you can see calcium complexing agent like sodium citrate, acid citrate, dextrose, sodium oxalate. This can also be used in the testing purpose, like in vitro anticoagulants. Okay. So now as a drug we use mainly the in vivo anticoagulants. The most common we can differentiate as a parenteral or oral. Parenteral anticoagulants, oral anticoagulants. Parenteral anticoagulants, the most common example is the heparin. Now the heparin can be unfractionated heparin. Heparin can be subcutaneous heparin, low molecular weight heparin, and there may be some heparin congeners like there may be some danaparoid, there may be fondaparinux, etc. Oral anticoagulants example is the some coumarin derivative or inandone derivative. For example, warfarin, acinocoumarol, phenydione, etc. And there are some newer novel oral anticoagulants like some direct factor 10 inhibitors like rivaroxaban. We will all discuss about. So these are the names of the anticoagulants. So again the same thing we can see, this is the parenteral or oral, and what are the targets? So this thrombin is the target in case of the bivalirudin, argatroban, hirudin. These are the direct thrombin inhibitors and these are also parenteral anticoagulant. Thrombin and factor 10A, these two are mainly targeted by means of heparin and low molecular weight heparin. Similar thing. Fondaparinux only targets the factor 10. While oral, you can see that thrombin is targeted by dabigatran, factor 10 is targeted by rivaroxaban, apixaban, edoxaban, and there are others like vitamin K antagonists. So there are different targets and accordingly we can use in different situations and different scenarios the anticoagulants. First starting with the heparin. Now this heparin is basically a non-uniform mixture or heterogeneous mixture of mucopolysaccharides. And the molecular weight is very large. It varies from the 10,000 to 20,000 Dalton. So it basically contains polymers of the two sulfated disaccharide units, D-glucosamine L-iduronic acid and D-glucosamine D-glucuronic acid. So it is a mucopolysaccharides that contains two units, you can see D-glucosamine L-iduronic acid and D-glucuronic acid, and they are very large heterogeneous molecules. They carry strong electronegative charges and is the strongest organic acid present in the body. So heparin is normally synthesized in our body. It is present in the mast cells in association with histamine. Okay, this is the strongest organic acid in our body. Present in all tissues that contains the mast cells, and richest source is the lung, liver and intestinal mucosa. Okay, so our lung, our liver and our intestinal mucosa contains the mast cells, and this mast cells contains large amount of the heparin. Commercially, it is prepared from the ox lung and pig intestinal mucosa. So commercial, the drug what we are using, they are prepared from this ox lung and pig intestinal mucosa. So they are basically acts as an anticoagulant, and it is a very powerful anticoagulant which acts instantaneously, which is in contrast to the oral anticoagulant. Oral anticoagulants usually takes time for its action, 3 to 4 days, but this heparin or this type of the anticoagulant acts instantaneously and very powerful. It acts indirectly by activating the plasma antithrombin. So this heparin or heparin like things, they do not have any intrinsic anticoagulant effect. Remember, heparin does not have any intrinsic anticoagulant effect. They basically accelerate the normal process of the anticoagulation that is already present physiologically. So in our plasma, there is already presence of the antithrombin. This antithrombin is again synthesized from our liver. This antithrombin acts very slowly with the thrombin. Okay, so ultimately the anticoagulation happens. This heparin basically accelerates the process of the interaction with the antithrombin, with the thrombin, as well as antithrombin and other clotting factors. This is in nutshell. So this heparin antithrombin 3 complex binds to clotting factors of the intrinsic and common pathway like factor 10A, 2A, 9A, 11A, 12A and 13A, and inactivates them, but not factor 7A operative in the extrinsic pathway. So heparin mainly acts in the diagram already you have seen, heparin mainly acts in the common pathway as well as the intrinsic pathway, but not in the extrinsic pathway. Okay. At low concentration of the heparin, factor 10A mediated conversion of the prothrombin to thrombin is selectively affected. So when the concentration is low, factor 10A mediated anticoagulation is mainly happens, while when there is high amount, both the factor 10A as well as the factor 2A, that is the prothrombin to thrombin, both of these are affected. So you can see this. So these are the areas where the heparin blocks. So heparin blocks the main things already I have said, that this prothrombin to thrombin, factor 2A to 2 to 2A and factor 10 to 10A. These two are the main areas where the heparin acts, and in the upstream they also blocks the different other areas, You can see factor 13, factor 12, 11, 9, etc. etc. So how this heparin mainly acts? So you can see this is the antithrombin molecule. Antithrombin is already present in our plasma, synthesized from the liver. And in our normal physiology, when the coagulation happens, anticoagulation will also happen, but very slowly. So unfractionated heparin, already we have said this is a very large molecule. So this large molecule basically provides a scaffolding. They provide a scaffolding like this, where there will be more easier interaction of this antithrombin with the thrombin. So you can see this is the scaffolding, the antithrombin, the thrombin attaches. Apart from the thrombin, you can see there will be conformational changes of the antithrombin molecule when it comes within the scaffolding. So this is a rectangular one, it comes to the triangular one. Just to give you an impression that there will be conformational changes when the heparin attaches with this antithrombin molecule, and this conformational changes also accelerates the process of binding of the factor 10A with the antithrombin, and ultimately its destruction. Okay. So both the thrombin as well as the factor 10A, thrombin means factor 2A, factor 2A and factor 10A, both are attaching with the antithrombin. The attachment increases approximately 20,000 to 30,000 fold in comparison to our normal physiology when the heparin is present. This happens due to the two areas, due to the presence of this long scaffolding and due to the presence of the conformational changes in the antithrombin molecule. Okay, that's why this too happens. Now what happens when we are cleaving this unfractionated long heparin to smaller molecules? So when we are using this unfractionated heparin, since they are blocking both this factor 10 as well as factor 2A, sometimes there may be more chances of the adverse drug reactions, there may be more chances of the bleeding, there may be more chances of the thrombocytopenia. And this bleeding also we cannot predict always, because it is a heterogeneous long molecules. Okay, so that's why when we are using unfractionated heparin, we have to monitor its action continuously. Okay, and monitoring is done by means of the different assays. So when we are fractionated these long molecules to smaller ones, it has been seen that we can prepare low molecular weight heparin. This low molecular weight heparin is short enough that will not provide a scaffolding so that the antithrombin and thrombin can interact more, but it changes the conformation of the antithrombin molecule that causes more binding of the factor 10A to the antithrombin, and ultimately there will be anticoagulation. And it has been seen that in case of the low molecular weight heparin, the chances of the bleeding, chances of the thrombocytopenia, chances of the unpredictability of its action all are diminished. So it is clear. Similarly, synthetically, it has been seen that even we are cleaving this low molecular weight heparin to only a pentasaccharide sequence. This pentasaccharide sequence is the main active form. Only these 5 saccharide units. This is synthetically formed pentasaccharide unit. This is known as the fondaparinux. It also produces a similar type of action. They will not form the thrombin antithrombin complex more, but they form the complex of the factor 10A with the antithrombin, and there will be still lesser chances of the bleeding, still lesser chances, more lesser chances of the thrombocytopenia, etc. So it is clear. So that's why the difference of the unfractionated heparin, low molecular heparin are similar like the synthetic pentasaccharides, etc. So unfractionated heparin is a long molecule that ultimately acts by 2 pathways, 2 mechanisms of action. One is, since this is a long molecule with molecular weight approximately 10,000 to 20,000 Dalton, usually if the molecular weight is greater than 6,000 Dalton, we usually call it as unfractionated heparin. They provide a long scaffolding. Within the scaffolding, the thrombin, antithrombin interact with one another, and their actions, this interaction is accelerated approximately 20,000 to 30,000 times of normal. And ultimately, this also changes the conformation of the antithrombin. So the factor 10A also attaches with this, and there will be anticoagulation. And when we are cleaving this unfractionated heparin to less than 5,000 Dalton, so these are known as the low molecular weight heparin, or still only the pentasaccharide form, if we are synthesized in the laboratory, it has been seen the side effects are less. They only changes the conformation of the antithrombin free molecule, and there will be more interactions of the factor 10A with the antithrombin, but there will be no interactions of the thrombin with the antithrombin. So ultimately the anticoagulation happens, but the adverse drug reactions will be less. And again, we do not need monitoring, regular monitoring of the whether there will be chances of the bleeding or not in case of the low molecular heparin or fondaparinux. Okay, so this is the difference between the mechanisms of actions. So the same thing it has been seen. So low concentration of heparin. So when low concentration of heparin acts like that of the low molecular weight heparin, so they prolong APTT without significantly prolonging the prothrombin time. High concentration ultimately prolong both the APTT as well as the prothrombin time. So APTT is the activated partial thromboplastin time, which is an indicator of the intrinsic pathway, and the prothrombin time is the indicator of the extrinsic pathway. So when we are using low amount of the heparin, that prolongs the APTT but not the prothrombin time. But when we are using very high amount, ultimately all the pathways will be blocked. That's why the factor 7 will also be affected and prothrombin time will also be prolonged. So sir, same thing, scaffolding and conformational change already we have discussed. So heparin also acts as an antiplatelet if it is used in high amounts. Lipemia clearing, it has been seen that they have lipoprotein lipase activity. So when we are using to its turbid plasma, there will be cleaving of the lipids, and the triglycerides will be went back within the cells. So this is known as the lipemia clearing effect of the heparin. Heparin is highly ionized. It is not absorbed orally. It is usually given intravascular or subcutaneously. Subcutaneously usually done in case of the low molecular heparin. It does not cross the blood-brain barrier as well as the placenta. That's why if we are asked that what is the anticoagulation of choice in case of the pregnancy, Heparin is the answer because the oral anticoagulants like warfarin will cross the placenta and will cause the teratogenic effect. So if in the pregnancy we need anticoagulation, we have to give the heparin. Usually the dose half-life is 1 hour, but it can be increased. So heparin basically shows both the zero order as well as the first order kinetics. So in the low dose, it follows the first order kinetics, but in the high dose, it follows the zero order kinetics. Its half-life will be increased. So it should not be given with penicillin, hydroxycortisone or tetracycline because there may be some interactions. Adverse effects, bleeding due to overdose or due to unpredictability if we are using the unfractionated heparin. Hematuria is the first sign, hematuria, that is blood in the urine. Thrombocytopenia may happen, aggregation of the platelets, and the one dangerous thing with the heparin is the heparin induced thrombocytopenia. That can also happen. Hypersensitivity may happen in some of the cases. Transient and reversible alopecia can happen. Osteoporosis, bone fragility, that can happen if we are using heparin for a long period of time. Hypersensitivity reactions already have seen. Heparin induced thrombocytopenia is particularly important because in some of the cases if we are using heparin, that can decrease the platelet count and that also leads to thrombosis. This is known as the heparin induced thrombocytopenia with thrombosis, HIT or HITT. So this is a potentially devastating adverse drug reaction caused by the emergence of the antibodies that activate platelets in the presence of the heparin. So antibodies are activated, platelet factor 4. So you can see heparin, when it is given, this platelet factor 4 is associated with the heparin complex. So platelet factor 4 heparin is formed and antibody, IgG antibodies can formed against this. So heparin, platelet factor 4, IgG immune complex is formed that can attaches with the Fc receptor of the platelets and there will be activation of the platelets, more platelet factor 4 release. So ultimately there will be the platelets can activated and they can be destroyed. So usually it is of two types. One is type 1 and type 2. Type 1 is the non-immune heparin associated thrombocytopenia. This is a non-immunologic response to heparin treatment mediated by the direct interaction between heparin and circulating platelets. So direct interaction between heparin and platelets that causes the platelet clamping and sequestration. It affects up to 10% of the patients, usually occurs within 48 to 72 hours after initiation of the heparin treatment. Okay. But the problem is the type 2, which is the immune mediated, typically occurs 4 to 10 days after exposure to heparin and has life and limb threatening thrombotic complications. So there will be decrease of the thrombocyte count there, but also there will be platelet plaque formation. That's why the platelet count is decreased, and due to the presence of this platelet plaque there will be thrombus formation. So ultimately there will be life threatening, that may be life threatening if it blocks the coronary artery or cerebral artery. It may be limb threatening, like my leg is lost. If it is blocked the deep vein of the leg vessels will not, leg cells will not get the oxygen. So life and limb threatening complications can happen due to heparin induced thrombocytopenia type 2. So heparin induced thrombocytopenia mainly happens due to the formation of the antibodies against the platelet factor 4 and heparin combination. So these are the contraindications of the heparin where we will not use the heparin, like bleeding disorders, history of the heparin induced thrombocytopenia. Bleeding disorders means, for example, hemophilia is a bleeding disorder, we will not use. History of the heparin induced thrombocytopenia, previously if there is history of the heparin induced thrombocytopenia. Severe hypertension because there is risk of the cerebral hemorrhage, threatened abortion, bleeding piles, gastrointestinal ulcer. In all these cases there will be risks of the further bleeding, more bleeding. Subacute bacterial endocarditis because there is chances of the thrombus dislodging and embolus formation. Large malignancies because there is risk of the bleeding in the central necrosed area of the tumor. Tuberculosis, again there will be more risk of the hemoptysis, blood in the cuff. Ocular and neurosurgery, lumbar puncture, more chances of the bleeding. Chronic alcoholism because the liver is already compromised. Cirrhosis, renal failure. Aspirin and other antiplatelet drugs should be used very cautiously during antiplatelet therapy because these are also antiplatelets. So there will be more chances of the bleeding. So these are the areas where we should not use the heparin. Low molecular heparin, already I have said that unfractionated heparin are cleaved in the laboratory to form the low molecular weight heparin. So they are being fractionated. Usually the molecular weight varies around 5000. They have a different anticoagulant profile that is selectively inhibit factor 10A with little effect on factor 2A. Already we have discussed. So factor 10A are selectively inhibited by low molecular weight heparin because there is conformational changes in the antithrombin. But there will be no scaffolding with the low molecular weight heparin. That's why there will be no effect on the factor 2A, that is the thrombin, prothrombin. So they act only by inducing the conformational change in antithrombin 3 and not by providing a scaffolding for interaction of antithrombin 2 with thrombin. So as a result, low molecular weight heparins have smaller effects on the APTT. So activated partial thromboplastin time, smaller effect, whole blood clotting time, and then the unfractionated heparin. Lesser antiplatelet action, less interference with hemostasis, thrombocytopenia is less frequent. So this is the same how the mechanism of action is there. It has been also seen that there will be lower incidence of hemorrhagic consequences. So less chances of the hemorrhage, major bleeding in every cases. They are eliminated primarily by renal excretion. They are not to be used patients with renal failure. So low molecular heparin is only excreted by kidney. So this is not to be given in the chronic kidney disease. We have to use the unfractionated heparin. They have better subcutaneous bioavailability. So bioavailability is better 70 to 90% compared to unfractionated heparin, which is only 20 to 30%. Variability in response is minimized because the long molecules, they are variable. In some persons there will be more anticoagulation, in some persons there will be less anticoagulation, but this variability is minimal in case of the subcutaneous low molecular weight heparin. They are longer and more consistent T-half, 4 to 6 hours. So once there is subcutaneous administration can be done. So it is predictable first order kinetics, longer T-half. APTT or clotting times are not prolonged to much extent. Laboratory monitoring is not needed. When we are using the unfractionated heparin, we have to use the APTT and also bleeding time, clotting time every weeks. But when we are using this low molecular heparin, we will not have to monitor so frequently. Risks of osteoporosis after long term use is also much less. So this is very commonly asked that what are the advantages of the low molecular weight heparin over the unfractionated heparin. So these are the advantages. So what is the difference in the mechanism of action? Is it clear? So this is the difference of the mechanism of action between the unfractionated heparin and low molecular weight heparin, and that's why the unfractionated heparin there will be more adverse effects, and low molecular weight heparin these are the advantages. These are all of the advantages. Okay, but it has been seen that low molecular heparins are equally efficacious to unfractionated heparin, except only in some large long time surgery like cardiopulmonary bypass surgery. Usually we are using the low molecular heparins as prophylaxis as well as the treatment after deep venous thrombosis, pulmonary embolism, stroke or other immobilized patients, unstable angina, myocardial infarction, to maintain patency of cannula and shunts in dialysis patients. So in these cases we can use the low molecular weight heparin. So low molecular weight heparin usually we can assay the factor 10 to see how is the action of the low molecular weight heparin. There are some low molecular weight heparin whose factor 10A ratio to factor 2A ratio is more, that is they are very small molecular weight low molecular weight heparin, and some are somewhat large, so that there will be more terms of the adverse effect. So there are different types of the low molecular weight heparin and they have different types of the profile. Okay. Fondaparinux already we have seen, this is basically a synthetic form. Only the pentasaccharide sequence is synthesized in the laboratory, because it has been seen that this pentasaccharide sequence is enough to ultimately change the conformation of this antithrombin tree. More or less this is seen, we can see less likely to cause thrombocytopenia compared to even the low molecular weight heparin, does not require laboratory monitoring of the APTT. Danaparoid lesser used now, previously used, which is basically a mixture of the heparin, darmatan and chondroitin sulfate, exert its anticoagulant effect predominantly by inhibiting the factor 10A, and they have near 100% bioavailability. Then coming to the direct thrombin inhibitors. So this heparin, low molecular heparin, etc., all acts by indirectly. They are known as the indirect thrombin inhibitor because they do not have intrinsic anticoagulant effect. They mainly accelerates the interaction of antithrombin with other clotting factors. But there are some direct thrombin inhibitors. So they bind directly to thrombin and inactivate it without the need to combine with and activate the antithrombin tree. That's why they have more chances of the adverse drug reactions also. Like lepirudin. Lepirudin is a recombinant preparation of the hirudin, which is a polypeptide anticoagulant secreted from the salivary gland of the leech. So leech mainly in the salivary gland, they contains hirudin. That's why there will be anticoagulation. That's why the bleeding will continue if the leech attaches with our skin. So from this hirudin, we are basically preparing the recombinant form. This is known as the lepirudin. This lepirudin binds firmly to the catalytic as well as the substrate recognition site of the thrombin and inhibits it directly. So thrombin, there will be two sites. One is the catalytic site, another is the substrate recognition site. It binds firmly with these two and ultimately blocks it. Injected IV, it is indicated only in patients who are at risk of heparin-induced thrombocytopenia. So basically, these direct thrombin inhibitors are now used in case of the heparin-induced thrombocytopenia or heparin-induced thrombocytopenia with thrombosis. On repeated or prolonged administration, antibodies can develop against this lepirudin thrombin complex. That can result in prolonged anticoagulation effect and possibility of the anaphylaxis. So this is the problem. Action cannot be reversed by protamine or any other antidote. That's why it is lesser use, lepirudin, which is obtained from the hirudin, from the leech. So these are the newer ones, bivalirudin and ergotamine. Bivalirudin is a smaller peptide prepared synthetically, actions and uses similar to lepirudin. Its action is slowly reversible due to cleavage of its peptide bonds by thrombin itself. Ergotamine is a synthetic non-peptide compound, binds reversibly to the catalytic site of the thrombin but not to the substrate recognition site. It produces a rapid and short-lasting antithrombin action. Administered by IV infusion, it can be used in places of the lepirudin, again in case of the heparin-induced thrombocytopenia. So directly, you can see direct thrombin inhibitors. Example are the lepirudin, bivalirudin and ergotamine. What are the indications? Mainly in case of the heparin-induced thrombocytopenia. Mainly these are used. And this is the heparin antagonist known as the protamine sulfate. Since heparin is the strongest organic acid in our body, this protamine is the one of the strongest bases that is present. So it is a strongly basic low molecular weight protein. This protamine itself have very mild anticoagulant effect. They are, when it is given IV, it neutralizes heparin weight by weight. Treatment mainly used in case of the heparin-induced bleeding. When we are using the unfractionated heparin, for example in cardiopulmonary bypass surgery, and after surgery, since we do not know when its action will be terminated, we have to use the protamine to terminate the action of the heparin. So otherwise there will be anticoagulation will be prolonged. So in these cases we can use the protamine. More commonly used when heparin action needs to be terminated rapidly after cardiac or vascular surgery. It does not neutralize fondaparinux, it only partially reverses the anticoagulant effect of the low molecular weight heparin. So you can see protamine mainly neutralizes the unfractionated heparin but little effect on the low molecular weight heparin and no effect on the fondaparinux. In the absence of the heparin, protamine itself acts as a weak anticoagulant, and being basic in nature, it can release histamine in the body and ultimately hypersensitivity reaction happens. So you can see these are the areas where the heparin acts, and the yellow ones are the areas where the oral anticoagulants act. So oral anticoagulants mainly acts where the vitamin K mainly acts. So vitamin K dependent clotting factors, already we have seen factor 2, 7, 9, 10. So you can see these are the areas where the vitamin K dependent clotting factor or oral anticoagulants mainly acts. So oral anticoagulants, remember the names, coumarin derivative like bis-hydroxycoumarin, warfarin, acinocumarol, inandone derivative like phenindone, of which the most important is the warfarin. Warfarin or warfarin sodium is most commonly used, but since there are different types of the adverse effects, we are more commonly used the novel oral anticoagulant drugs. So warfarin mainly acts by blocking the vitamin K dependent clotting factors. So warfarin and in its congeners mainly acts only in vivo. There is no action in the in vitro action. This is so because they are blocking the vitamin K dependent clotting factors in the liver. So they apparently behave as competitive antagonists of the vitamin K and lower the plasma levels of the functional clotting factors in a dose dependent manner. So how it acts until this today? So you can see, so vitamin K, you can see this is the base carboxyprothrombin, that is the zymogen form of the coagulation factors. It is activated. This activation happens by means of the gamma glutamyl carboxylase, and in the same time vitamin K hydroquinone is converted to the vitamin K epoxide, and then again it will be cycle back. So ultimately this cycle will be continuing. So when we are using the oral anticoagulants like warfarin that blocks the conversion of vitamin K epoxide to vitamin K hydroquinone and at the same time NADH to NAD by blocking the enzyme vitamin K epoxide reductase. So when this is blocked, so ultimately vitamin K hydroquinone, there will be less formed, they cannot be converted to vitamin K epoxide. So this factor 2, 7, 9, 10 again cannot be converted to activated form of the factor 2, 7, 9, 10. So ultimately there will be less synthesis of the factor 2, 7, 9, 10. So this is the way by which the oral anticoagulants like the warfarin mainly acts. So it is clear. So heparin mainly acts indirectly by accelerating the interaction between the antithrombin and other clotting factors. Warfarin and other oral anticoagulants mainly acts by blocking the conversion of vitamin K epoxide to vitamin K hydroquinone by blocking the enzyme vitamin K epoxide reductase, and thus they are blocking the synthesis and conversion of the inactivated form of the factor 2, 7, 9, 10 to its activated form. So this is the way by which the oral anticoagulants act. So until this, in the next class we will discuss about the oral anticoagulants and then antiplatelets, fibrinolytics and antifibrinolytics. Just one anecdote, this heparin, do you know who invented this heparin? Who discovered? Exactly. Yes, MacLean is a second year medical student like you. Second year medical student, it has been seen that there are some anticoagulant that is synthesized from the liver, and it was again synthesized in after 4 or 5 days, and then it is named as heparin because it is obtained from the liver. Okay, that's why.